Perfect. Perfect. Great. So I'm just waiting for you to start to introduce, right?
Yes, Doctor.
Okay, okay. Also, Mr. Ashraf, could you tell me when will it be available on YouTube? Is it just right after the streaming? It's on there?
It is already available, so we are streaming right now.
Okay. So it's only online, it's not then.
It will be a recorded session as well, but if you'd like, we can remove it.
No, it's okay. It's okay. I'm fine with that.
Hello everyone and welcome back to the Oral and Maxillofacial Surgery webinar series. My name is Omar and I am the webinar director at the SCORE committee. It's a pleasure to have you all with us today for the fifth session of this series. Before we begin, I would like to briefly introduce the International Association of Dental Students, IADS. IADS is the largest global organization representing dental students worldwide, connecting students from different countries and creating a platform for academic exchange, professional development, and cultural collaboration. This webinar series is organized under the SCORE Office of IADS. SCORE stands for Standing Committee on Research and Education, and it focuses on research, education, and international collaboration. Through the SCORE initiatives, students have the opportunity to engage with experts, participate in global projects, and gain valuable learning experiences. We hope you will find this today sessions insightful and beneficial, and it's a great pleasure to welcome Dr. Jan today, and we sincerely thank him for sharing his expertise with us today. To introduce our speaker and guide us through the session, I would now like to hand over to my colleague Adham.
Thanks, Omar. Today's topic, guided surgery from plan to precision, introduced by MD Dr. Jan Hulvert from Czech Republic, major dental aesthetics. His biography, Dr. Jan is a dentist and founder of Prisma Clinic in Prague, Czech Republic. His clinical focus includes restorative dentistry, orthodontics, periodontology, and surgical procedures, with a strong emphasis on digital workflows and predictable clinical delivery. He is a certified member of the Czech Academy of Dental Aesthetics and received the Aesthetic Restoration of the Year award in 2019, 2020, and 2022. The floor is all yours now, Dr. Jan.
Thank you. Thank you for the invitation. Thank you for the great introduction. So I'll start sharing the screen now. So just let me briefly know if you can see. Is it everything shared and can be seen?
No, doctor, not yet.
Not yet? You don't see the screen now?
Nope.
Yes, please.
Okay, so we'll just
We can.
adjust it. Just a moment. This will be better probably.
Yes, now we can see it.
Perfect. So I'll go right away into the presentation itself. So now we can see and you can hear me, right?
Yes.
Perfect, perfect. So the topic that I chose is called guided surgery. We all probably know guided implantology. So that's cases where we use guides to being able to place implants. But there is also a topic that's like above the guided implantology, and that's guided surgery, because we can use the same principles just to guide ourselves, not only in placing implants, but also in doing other procedures. And we'll go through them all. So I've already mentioned that it can be guided to do the implants, but it can also be guided to do some other osteotomies like lateral sinus lift. We can also use the guided surgery to remove some foreign bodies from the bone, also from soft tissues. And yet we can also somehow guide ourselves when doing outer transplantation of teeth. And I would like to go with you through these topics of guided surgeries, through these procedures one by one. But before that, we'll just go through what guided surgery actually is. So what guided surgeries have in common? It's the osteotomies. So the osteotomies means that we are actually cutting into the bone. And also, because we're talking about guided surgery, what it also has in common is that we use guides. For osteotomies and for us to be able to cut into the bone, it's essential for us to have something that we call CBCT data, and it's usually in DICOM format. For us to be able to create guides, we need something like STLs, which is an abbreviation for Standard Tessellation Language, which is actually a file that will show us what the 3D object looks like in virtual life. And based on that, we are able to create guides. So if we want to plan to do guided surgery, it means we're planning to do osteotomy. If we want to be guided, we want to create a guide. And to be able to create a guide, we need to actually have the virtual 3D object, which is the STL. Based on that, we can do the guide. And based on the CBCT, we have the data about the bone that we will be cutting. So what's actually the CBCT? We'll go just briefly through the theory of the CBCT. The DICOM file or the CBCT is usually compiled from little voxels, which are like little cubes. And the resolution of the DICOM file depends on the size of the voxel. The lower the size or the lesser the size of the voxel, the higher the resolution of the CBCT is, the more accurate. But also, this kind of high definition CBCT or high resolution CBCT will take a long time to be exposed. Also, it's a great radiation or greater radiation than if we do some moderate resolution CBCT. So I recommend to do something, the resolution to be where the voxel size is about from 50 to 100 microns. And you put the voxels together, but also the DICOM file, it doesn't only contain the information about the bone, We need to think about it as an object that also holds information about the soft tissues. And it only depends on what threshold we choose to visualize data. Because we all know that the CBCT can be seen through its cuts, like the horizontal cut, sagittal cut, frontal cut, coronal cut. And through these cuts, we can measure, we can see the bone. In this case, we can see the implants, and we can analyze the data. But the CBCT data can be also so-called rendered. That means that we can actually see the 3D object. And when we are doing this rendering, we always played with something that's called the visualization threshold. So we're actually able to shift the threshold guide from left to right. And then based on radio opacity or radio density, we can only visualize things that are very, very radio opaque or very, very radio dense. For example, enamel or foreign bodies, gutta percha, and stuff like this, or bone, cortical bone, or we can lower the threshold to be very, very sensitive, to visualization to be very sensitive, and then we can also see soft tissues. That's something that you could see actually all the way in the beginning. So it's actually possible to visualize soft tissues with CBCT when rendered. So this is a thing to bear in mind. It's also very important when we do something that's called segmentation. Segmentation is that we take the DICOM data and we segment the data so that the data will be delivered separately. So it can be crown with roots as a tooth itself, it can be lower jaw itself, it can be upper jaw itself. Also, it can be that we only separate gingiva. And this segmentation is using via some AI technologies, but it's using what I just said, it's using the thresholds. And then when we look at the STLs, that means the files of the 3D objects that can be seen in virtual life, we need to bear in mind that it's always something like a point cloud that's trying to visualize what we usually scan in our offices with intraoral scanners. And these 3D objects, the STLs, are actually contained of little triangles that are puzzled together to visualize the 3D object. And what's the point of guided surgery? It's alignment of CBCT with the STL together. So based on this functionality, where we align the CBCT with the STL, we're able actually to guide ourselves during surgeries like implantology, like other osteotomies, as I said. It can be lateral sinus lift, it can be periapical surgery, and others. So that's something what the procedures that I described have in common, and it's using guides and doing osteotomies. The guided surgery also involves, of course, the most famous procedure of guided surgeries, and it's implantology, guided implantology. But also there is one important thing, especially in my country, we're usually saying that we're doing navigated surgery or navigated implantology. But most of the times people are actually not talking about navigated surgery or navigated implantology. They're talking about guided implantology. Specifics of guided implantologies are that we are using surgical guides, as I already have said, and those guides are static. So they're not moving, and you're only using them to go usually through some holes that you create statically through this hole to get to the place where you want to be. And they guide you physically. So you touch the sleeve where you put in the drill, the burr, the implant, whatever, and it guides you physically to the place where it wants you to be or where you plan to be. In contrast to it, navigated implantology is usually using some navigational system. And you can also compare this, or you can also see connection with our regular life when you use navigational systems like Waze, Google Maps, or stuff like this. It's actually a navigation because you're using a navigational system by this app, for example. It guides you with the software. It tells you where to go and you go. It doesn't guide you physically itself. And also your decisions and the navigation is dynamic. So if you, for example, you can either drive a car and you miss the turn, it dynamically changes the situation. So it's the same in mouth. If you are using the navigated implantology systems, it tells you where to go dynamically. So if you, for example, when placing an implant, move a little bit more to the right or left, it tells you to go back. So it changes the navigation dynamically. And there are also systematic reviews that confirm what I'm just about to give you as an information, and that's that in systematic reviews in literature, they also talk and they also divide the guided surgery and navigated surgery. So today we'll be talking about the guided surgery, not the navigated surgery. The dynamic navigation, the navigated surgery usually use some very complicated hardwares that are very expensive nowadays. It's for sure has its future. It for sure will make sense to use in future, but so far it's not very effective. For example, and I have those prices in Czech crowns, so we can divide it by 25.5 euros, but it doesn't really matter because the break-even calculation is still the same. So we have this machine, X-Guide, costs about 1,200,000 crowns in our country. And if we compare it to the guided surgery, for one guide, if you delegate it, if someone else designs the position of the implant and you just confirm that the position is right and they create the guide for you, you pay, for example, for something like 2,500 crowns, which is I would say like 100 euros. And the X guide costs like 1,200,000 crowns, which I think is close to, I think, 50,000 euros. So if we count with 5 years of depreciation means for how long you count with the machine to be working. So you have to divide the price of the machine by the time you'll be using it. It's usually counted like 5 years, even from the accountant point of view. That means that yearly it costs you something about 10,000 euros, which is like 240,000 crowns, Czech crowns. So if you place 132 implants yearly, and we have 231 working days, then it would mean that you would have to place about 0.57 implants daily. So it means like almost every other day you would have to place an implant. So it's possible, but it would mean that you're really specialized implantologist, and especially very, very high experts in implantology, they don't have to use those guides as much. So actually, even for them, it would be hard to place so many implants guided to be able to so-called break even with the navigated implantology system. And I'm just counting on the economics of each of guided implantology and navigated implantology and telling you that it would take like one implant every other day to place just for it to be break even. But we also have to take in mind that so far the literature says that there is no significant differences for the accuracy parameters of immediate implant placement with the static and dynamic systems. That usually that basically says that it doesn't really matter if you use guided surgery or navigated surgery nowadays. Its accuracy is pretty much the same. That means that we can have something that's very cheap and we don't have to invest so much in it and still have the same accuracy. And I'm emphasizing that it only means nowadays. In the future, for sure, navigated implantology as its cost will go down, the accuracy will be better, hardware will be smaller, more reliable, the same with intraoral scanners. So then it will be incorporated and implemented in our offices more and more. But so far, I think guided surgery is the way to go. And the studies say that it really brings accuracy. So if you compare it to regular freehand implant placement, the fully guided surgery usually brings you twice as more accurate results than the freehand implant placement. So that was compared guided surgery, navigated surgery. So now we know what's the difference and what we're talking about when we're saying that we're talking about guided surgery. So first, what we'll go through is something that most of you knows, something that you can see usually in social media and lectures, and that's using guides for the implant placement. Here we have a case of a patient that comes with a loose bridge in the frontal area, and she knows that there is something going on. So we do little x-rays, we do photo protocol, we do scans also, and what we can see in the intraoral x-ray that the right upper teeth, especially number 14, the first premolar on the right upper side, is having a great caries, probably only to be extracted. And we also knew that the right upper canine also has its crown loosened. So we can also expect there to be a great cavity, and we're not very sure about if we will be even able to do a provisional bridge when we'll be removing this old bridge from the patient. So we're thinking about removing one of the teeth, and you can also see the other situation, the implants in the distal area. So what we did, that we planned the appointment for the patient where we will remove the bridge and we will see what's left below this old bridge. And we were also a little bit afraid that below the bridge there might be whole cavities and we might not be able to do a new provisional bridge. So that's why we created this like an aligner that we just filled in with a flow composite just to just create some kind of provisional, removable provisional for the patient in case we will not able to do fixed provisional. So we removed the bridge, and what we could see is something that we could expect, or we expected. So the right first premolar was unfortunately to be extracted. The same was for right upper canine. So we thought maybe we could survive with the left central incisor. Maybe we can have the left upper canine to be restored. And actually the left upper canine was in the final decision the only tooth that could be saved, because even the central incisor had its fracture, vertical fracture. So even this tooth was planned to be extracted. But then if you have this patient or some patient like this, and you have implants in the distal area and also other teeth to be extracted, it doesn't really make sense to leave the last teeth, the left upper canine, to be there and restore it with the crown. So we decided even to remove that. So now you have to think, so we have this patient, we have this aligner ready just to give her something to have a provisional, and we know we're gonna go for implantology. In these cases nowadays, we all do it guided. Even if it's experienced surgeon, he always does guided, because actually the study that I showed you, the literature that I showed, they're showing it's having the guided surgery brings much higher accuracy, even for experienced surgeons, because it's actually impossible to place the implants into the visualized position without being guided as precisely as with the guide itself. So we did intraoral scan without the teeth. We also did the scan with the final restoration that was there with the old bridge. And we left the patient with this aligner as a provisional. Now, you always have to think about in these cases, because you'll be doing CBCT just to have the bone to be able to plan the implant, right? As I said, you also have the intraoral scan. And just to plan it, as I said, the basic functionality, and that's probably the main key point I want you to take from today's lecture, is that you have to align the scan with the CBCT. And to be able to do it, you have to have at least few rigid similar areas on the CBCT and also on the STL file on the scan, because those areas are those that you will define so that they will be counting into the alignment. Because if you think about this case, for example, and you have metal ceramic crowns in the distal area, you do the CBCT, and this is what the CBCT looks like. there is for you no similarity to the intraoral scan. So what you have to do, you have to, even before the patient goes to have the CBCT done, you have to create this reference. So you can, for example, take a radio opaque flow composite and do this kind of a mesh that you can see on the palette side, which is here on the photograph. And you do the intraoral scan with this flowable composite. But you also send the patient to go to have the CBCT done with this flowable composite. And because you already had the information from me that you can move with the threshold area, you can move with the threshold and the sensitivity of the rendering. So then if you have the high opaque flow and you just lower the sensitivity of the threshold of the visualization as much as you can actually see the composite mesh that you created. And this for you will be the reference for the alignment of the intraoral scan with the CBCT. Because then, no matter what software you use, you can always define what areas will be used to be aligned, to align the CBCT with the intraoral scan. So what you do, you first do something that's called initial alignment. For example, you choose 3 similar points on the scan and on the CBCT, but then, this is crucial, you just select exactly the area on the STL that you know that can be greatly seen on the CBCT. And that area will be used. And then you can check, you can see the green line is the intraoral scan. And of course, the shades are the CBCT of, for example, soft tissues. You can see how perfectly it aligns there and afterwards. And now you're ready to do the plan for a guided implant placement, for example, or you can do any other guided surgery, as we will show you later on. So because actually the old restoration the patient had was not that bad in terms of the teeth position. So we also created a portrait photo of the patient with the old bridge before we removed it. We also did the scan before we removed it. And thanks to that, what we could do, we could actually connect the intraoral scan with the portrait photo, and then based on that, we can also connect the pre-op scan of the old bridge with the scan without the teeth. And based on that, we can plan so-called prosthetic position of the implants. We can also plan the guides based on the position of the implants. So I'll go through it again. You have the portrait photo. You connect the portrait photo with the pre-op scan before you remove the bridge, but you can also connect the scan after those removing of the bridge with the pre-op scan, and based on that, you can actually plan exactly those implants where they need to be in relation to the future prosthetic position. And here you can see the future prosthetic position, for example, of the right upper first premolar. And you can also see that it seems like we'll need to do crestal sinus lift. If we have a look at the left upper canine, based on what you can see that on the vestibular side, the cortical bone is very thin. So we need to think about the procedure just to preserve the bone there and to keep the volume, which will be a socket shield. And the same socket shield technique I've planned for other teeth is also right upper canine and left central incisor. So we go one by one. This is the guide being placed. And we'll start with the tooth 1-4, which is the right upper first premolar. We extract the tooth. Once the tooth is extracted, because we don't do socket shield here in this area. So after the tooth is extracted, we place the guide, which is the second frame. On the placed guide, you can see that there is a hole from the side of the sleeve. What I use so-called monolithic sleeves. They can also call them sleeveless guides. They call them sleeveless guides because they don't have the metal sleeves in it. And that also allows me to, in software, create a little hole for the irrigation to get in there and to actually irrigate the burr. I know those systems are created, so they tell you you don't need to irrigate, but it's always better for me to have the irrigation in there because of the heat. but also because it removes the detritus and also reduces the friction. And when you reduce the friction, you also lower the heat. And when you lower the heat, you increase the chances of the implant to be healed. So in this case, we were doing the sinus lift. So you can see actually through the hole that I just prepped, that we got to the sinus, but not through the sinus epithelium. And we actually elevate the sinus epithelium for us to be able to augment it a little bit and to place the implant in there. And this is what you can see just through. This is very minimally invasive sinus lift because you don't elevate the flap at all. There is no swelling afterwards, no high sensitivity. And then we start to place the implant, also through the guide. And other teeth were treated with the socket shield technique. What the socket shield technique just briefly is about, you leave part of the root where you want to leave the periodontium. You know that all around the root is a periodontium, and we actually know that these periodontal cells and tissues around the root are nutrition for the bone that's surrounding the root. So especially in the vestibular area where the bone is very thin, this part of bone is actually nourished with the periodontium from the tooth. So if we leave the part of the root on the vestibular side, as you can see on the image on the right lower corner, what we do by that, we just help the biology of the bone for the bone to stay there and not to resorb, because we leave the periodontium there. If we would extract the tooth all the way out with all the periodontium, this part of the bone would resorb because it would die. It would have no nutrition, no nourishment, no blood supply. And we did that with all the other teeth. Something that I also started to do with the guided surgery and with digital technology itself, right after I place those implants, I right away take something called immediate scan. It's much easier to do than do silicone impression in this case. And that will also allow me to do something that's called early, or what I call very early provisionals, that we can give the patient in about 3 days. So I place healing abutments back on the implants, and I will leave them there for 3 days until the day where we'll have the provisional bridge to be fixed. And I don't use some individual healing abutments in this case. I would use them if I would count with them for another weeks. But if I know that those healing abutments will be there only for 2 to 3 days, I can leave them as they are, some regular shape as they have. I don't need to individualize them at all, because the tissues will be still swelling around the provisionals that will be fixed in there in about 3 days, as I said. And patients sleep with the aligner, as I told you. And how do we plan the provisionals? Because we had the shapes of the old restoration, which was quite good in terms of shapes and positions. So we changed the shapes a little bit. Because we had the portrait photos, we could already check what the restoration will look like after we'll be fixed and luted, or fixed, not luted, because it's screwed, retained. And actually in this case, because it was just immediate provisionalization, it was not immediate loading. That means I gave the patient the bridge, but it was not loaded. I just placed it in there. And you can see this was printed. It could be printed because, as I said, it was not loaded. And this is the accuracy of the printer that we have. It's a printer, very cheap. It's, you will not believe me, it's like 200 to 300 euros. And it does a perfect job, very, very perfect job. So this is the bridge, and this is actually screwing in the bridge. But we can also plan, when we plan the provisionals, we can also plan to shape the soft tissues. So we can shape the provisionals in perfect shapes and actually not count with the soft tissues at all. So because you can see, I cannot really place the provisional bridge all the way into the implants, because it's stacking in there in the area of central incisor. That's on purpose, because I will be actually that ovoid part, like sinking in the soft tissues and creating space for the ovoid part. And with the volume of the soft tissue that I'll be removing to create the space, I will use this volume to place it on the vestibular side. Because in these cases, actually, sometimes you have enough tissues vertically, but you don't have enough tissues on the horizontal dimension. So you can actually transfer the horizontal, the vertical excess to the horizontal part, or to horizontal area where actually you don't have enough of the soft tissues. So this is something that we can also call it the punch technique. And what we do, we just remove the parts of tissue and we place it on the vestibular side. You can see it there by seeing the stitches. And this is actually in 14 days. So you can see papillas being there, shaved more or less in some areas. And then we did back in there, we did silicone impression. Nowadays, I would use intraoral scan in this case, for sure, because we segmented the prosthetics. My limits of intraoral scanning for prosthetics on implants is actually 4-unit bridge. So this is actually on the edge of being able to scan intraorally. If we start to connect more implants or bigger sizes of prosthetics, like more than 4 units, like 5, 6, 7 units, then the inaccuracy of intraoral scans that we know that is there, that it's full literature talking about the inaccuracy of the intraoral scans. So then we risk highly that we will actually break the prosthetics when we'll be screwing it in. And that's also the reason why we segment the work like this. So if it's FP1 or FP2 reconstruction, and if you don't know what FP1, FP2 is, please have a look at it, because FP1, FP2, FP3 is like the basics on dividing the materials, but also the shapes of the prosthetics on implants. So in FP1 and FP2 cases, I tend to segment the work and use intraoral scans to do zirconia bridges. So we just then change the material after 4 months of healing of the immediately placed implants. So that was actually guided implant placement. Now we go to guided osteotomy in terms of lateral sinus lift. So as in this case, you can see what you can do. Again, connecting the CBCT with the intraoral scan, you have it. Then you actually can have a look at the CBCT where you will be placing the osteotomies to do the lateral sinus lift. But first, as you can see in this image, you will always start with planning. When planning, you will connect the intraoral scan with the CBCT. And after you do that, you will place so-called library tooth. Based on the library tooth, you will define the right prosthetic position of the implant. Once you have that, then it's time to evaluate, do I have enough bone? So never evaluate if you have enough bone prior to planning the procedure. So you first you place the library tooth, something that we call setup tooth. So first place the library tooth. Then based on that, you will place the planned position of the implant. I will pause the video because this is very, very important. So we go through this again. As I said, the first take-home message today is you need to be able to connect the CBCT with the intraoral scan to do guided surgery. That scan, that CBCT should not be older than 14 days. Just take this in mind. That's first take-home message. The second take-home message is what you see actually in this slide. You first plan the setup tooth. Then, based on the tooth, you plan the right prosthetic position of the implant. And then you evaluate whether you will need to augment. And if you need to augment, if you don't have enough volume, do I have enough volume of the bone? Or do I have enough volume of the soft tissues? Because if there is not enough soft tissues, I need to fill in the soft tissues. If there is not enough bone, I need to fill in the bone. It's easy. So in this case, I could see, and you can see also from the view inside, the sinus right here. that there is not enough bone for sure. And it's in the area where the implant will be. So we need bone in there. Sometimes you can see there is not enough volume, but the implant is already in the bone in its plant position. So then you can think about only filling in the soft tissues. So this will be augmented with a sinus lift, and it will be a large augmentation. So we decided to go from the lateral approach, but it's always, when you begin with these types of surgery, it's always hard to tell where the window of the osteotomy will be. Where exactly should I open the sinus just to be high enough to be able to perforate the bone and to see the sinus epithelium that will be elevated. So you can also do it, as I showed you, by planning positions of these pins and then actually really use those pins to define exactly the corners of the window that you'll be creating, like this. So we'll connect that, and then it's a different case, but similar scenario. Then you actually remove the lid like this. And you can see the epithelium of the sinus that can be elevated. And that the next step is to slowly go and slowly elevate with special instruments. Very, very carefully. It's usually 1 or 2 layered epithelium, very sensitive for perforation, very prone to perforation. So you have to be very careful and go in contact with the hard underlying bone just to elevate the sinus mucosa. Once you do that, you just pack in the bone as much as you can. And then once you pack enough, you can actually put the lid back. It's something I do. Sometimes some surgeons, they throw it away, or they maybe put it in the mill and mill it and then use it again for the augmentation as an autologous graft. But what I do, I place the lid back and I just like put it below those undercuts and fix it in there so it stays. And actually, in some cases, you risk that you can have an extrusion of the augmented material, but if you place and fix the bone lid like this, you will not have the extrusion of the material afterwards. So that's why I do it. And as you can see, X-rays pre-op, right after the augmentation, and then after 6 months ready for the implant placement. This is something, and you can also see why it's recommended to over-augment the volume, because after the surgery, you will always have the reduction, as we have here. It can be 30, 40, even 50% of the volume. So always over-augment in these cases. Another case is removing of a foreign body. And it's actually something that the software systems are not designed for. But again, as I told you, you can use the threshold to visualize where the high opacity, highly radiopaque foreign body is, find that, and actually plan position of an implant, the shortest possible implant, ending with its apex in the place of the foreign material. And when you do that, then you can create a surgical guide. And when you create a surgical guide like this, you can actually access the foreign body with the drills, because those drills will be drilling in a place where you place the implant. You will not be, of course, placing the implant in the applique area at all, but it's a way for you to get to the exact depth of drilling and also to the right place of drilling. So as you can see in this case, patient came in asking for replacing of the tooth of the right upper first premolar. So we did. I raised the flap and I had the guide, and I had 2 guides. I had one guide to place the implant and one guide to remove the foreign body. So I used the first guide to access actually the area of the foreign body. And you can see that it's accessed already. You can see the gutta-percha. So I'm using also the drill just to remove it completely. And after that, I can place another guide, and that other guide is exactly for what you can see, is for placing the implant itself. So we actually used 2 guides. One was to remove the foreign body, and the other one was to place an implant. Excuse me. So here is implant placed. Also, you could see there's slight recession. When you do surgery in contact with the tooth with the recession, it always asks you. So maybe you can release the soft tissues a little bit more with cutting periosteum. It's like modified Tsukali approach here. And what you will do afterwards, or what I was able to do after releasing the flap like this, just to do harvesting of the connective tissue graft. And as I told you, that flap was like Tsukali inspired. This is also like Tsukali inspired graft harvesting in the area of upper molars. So I'm taking epithelial connective tissue graft and I will deepithelize this graft outside of the mouth. And we'll place it below the release of tissues. And you can see, actually, this is after the one surgery. We remove the foreign body, we place the implant, and I also try to cover the recession. This is what it looks like after 3 months. The implant is healed, recession is healed, and we can place the crown. This is actually the final X-ray. You can see that the foreign body is not there at all now. And we're going to the last case. The last case is auto-transplantation. And I'll show you how to use the principles that I just explained to you in planning actually the auto-transplantation. The auto-transplantation was a case where a patient had tooth retention and we need to take it out. And we actually, in this case, what we are planning to do, place it in a bone bed that will be created, because sometimes you can place the auto-transplanted tooth right into the extraction socket. This is not the case. We needed to drill. And when you need to drill to create a space for the future root, it's always hard to drill enough and to drill the right size. And that's the part that's guided in auto-transplantation. So if you extract the tooth and you replace it with other tooth, it's the regular conventional auto-transplantation. It's not as hard as if you have to drill in healed bone just to create the space to auto-transplant the tooth. And because this part is hard, it's always good to be guided in the hard part. So what we do, we actually simulate placing the tooth in there when it's segmented. And I also was talking about the segmentation already. And we plan the implant in the area where the root of the premolar, in this case premolar, of the auto-transplanted tooth will be. And then we'll also have a guide. So we'll be drilling like if we were able to place an implant. And we will not be placing an implant. We'll be actually placing a root tooth with the root. So that's why we're choosing the size of an implant that's very similar to the size of the root. And we always, it's never perfect when drilling with the guided drills. It's never perfectly ready for the auto-transplantation. We always need to make the place a little bit bigger just to be able to place also the tooth in there to auto-transplant. But it will give you a lot of information, and it's not as hard as drilling from zero without the guide. So it's conventional bone bed auto-transplantation. As in this case, it was lower premolar retention with the also already pericoronal lesion being in there, and the tooth was in the orthodontic department asked me to auto-transplant the tooth because they were not able to place the bracket on the tooth because the tooth was on the lingual side. So actually, this is what we did. We reviewed the case. We connected the CBCT with the scan, and I segmented the data. So we can actually see all the teeth segmented and the bone segmented, and also the canal, mandibular canal segmented. And I simulated the right position of the tooth. And after the right position, a little bit in infraocclusion because it's crucial for the tooth to heal properly, not to be loaded when transplanted. And then because I had the exactly accurate dimensions of the root, I chose actually an implant that had a similar size in that area. That told me that, okay, if you want to have a space for this type of implant, actually for this size of a root, you will use these kind of drills and you will have the right space for the implant, actually, in this case for the root, with the guide. So this is another workflow. And then clinically, I just raised the flap, used the guide with the irrigation, as I told you already, then drilled. Then I always have two replicas printed of the tooth that was segmented. So I segmented tooth to be auto-transplanted. I print, and one, I leave them with supports on the left side that you can see, because that one I can easily hold and try into the socket, and the other one without the supports. That's because I also want to try if I can place them deep enough so that it doesn't interfere in the occlusion. That's why I have two of them. So I first try to place the tooth into the bone just to make sure that I prepped enough of the bone. And then I had the other replica to try if there is enough space in the occlusion. And once I found out that, okay, the room for the transplanted tooth is big enough, I could actually go and extract the tooth from the lingual side. And this, you can see how greatly, accurately the tooth is actually segmented and then printed. It's very, very, very similar in size and shape. So it's pretty much the same. And then I place the tooth in its position, fix it. And this is after 4 weeks, where we remove the stitches and remove the splint, and the tooth is ready. And here is a brief video of what it looks like in dynamic. So this is step by step what I told you, but it's in video, so you can have a look again, just to recapitulate it. So this is the plan, and now we go and execute. And it's actually a principle of digital dentistry. It's great. You can always plan, you can always simulate and analyze, and then be guided. That's what digital dentistry is for me. You can easily simulate what you want. You can analyze it. You can see what it would take to make it real, to execute. And then it's very hard to execute. Then you can make guides to guide yourself, basically for anything, even for preparation of teeth. So this is the tooth that was extracted, and I also removed the soft tissues that were there, the coronal sac. And this is 2 weeks post-operative. This is the X-ray before and after. The tooth now it's actually survived, because you can see that the apex is open. So these teeth with open apex, they can survive the autotransplantation. And you can see after the autotransplantation that their pulp and canal will start to obliterate. And it's actually confirmation that the tooth survived. This is something that you want to see. And you can see it here. It actually also erupted a little bit into its occlusion. So that's about it. That was guided surgery, implantology, guided sinus lift, guided resection, guided removal of foreign bodies, and also in final case, it was a guided autotransplantation. Thank you very much for your attention. If you have any questions, I don't know how it works here, so you can maybe ask. Maybe you can, if you have other questions, you can text me on Instagram at Jan Hulvert. And thank you very much for your attention. Thank you for the invitation. I'll be glad to see you next time again, maybe with some different topic.
Thanks a lot, Dr. Jan. We are waiting for questions now, and we have the first question.
Okay.
In cases of guided sinus lifts, how do you ensure the precision of the lateral window osteotomy via a guide without risking damage to the underlying Schneiderian membrane, especially when dealing with thin cortical bone or septum?
Great question. So there is 2 steps in this procedure that are very sensitive for you, where you can perforate the membrane. The first one is, as you could see, I would define the corners of the osteotomy. That's with the drills. The guided surgery, when you have it calibrated, it's so precise that you don't have to be afraid to perforate. Actually, it's usually the cortical bone is at least 0.5 millimeter or millimeter thick. So if you place, when planning, those drills that guide you to create those corners of the osteotomy, you place them just in slight contact with the bone, and that you will not perforate. And then the second step that's crucial to manage is to connect those corners with the osteotomy. And that's perfectly slowly, but precisely and very safely done with piezo instruments. So those piezo instruments, like ultrasound instrument, with usually I use for this type of procedures, piezo with a tip that's with a diamond coating. But you still have to be careful. So piezo is great. So if you are in contact with hard tissues with piezo, it preps. But if you go into contact with soft tissue with piezo, it stops prepping, because the logic behind the prepping is that the moves are so frequent and so slight, but so frequent that you're actually like drilling with the tip. But if you touch soft tissues, then because the amplitude of the frequency is so high and the amplitude is so low of the movement, you actually move with the soft tissues and you don't prep them. But if you go into contact with the hard tissue, you prep them. So that's why it's good to use piezo. But you still have to be careful. If you press too much on the piezo, you can easily go through the mucosa. So be careful, but use piezo, and then you'll be safe.
Thanks a lot, Doctor. We will now present the feedback and attendance form and proceed for the second question. When transitioning to guided periapical surgery, how do you manage the inherent blind spots in the digital plan, such as the exact root end anatomy, to ensure the guided resection achieves the necessary 3 millimeter depth and zero bevel with high predictability?
Phew. Could you maybe say that again, the question?
Okay. When transitioning to guided periapical surgery, how do you manage the inherent blind spots in the digital plan, such as the exact root end anatomy, to ensure the guided resection achieves the necessary 3 millimeter depth and
Oh, I get it. You know what? I can show you what we can do. Am I still sharing the presentation?
you can now, Doctor.
Okay. So what we'll do, I will open a different app where I'll have my photos, and I'll show you a photo of a guide for periapical surgery, okay? If it's possible, like this, to do it.
Yeah,
Okay.
you can share now.
Okay. So what I'll do, I'll open my database of photos, and I will open specific case. I wanted to put it all together into this keynote presentation, but I was not able to do it because of time management today. But we can do it. I will open the app with the photos, my Lightroom, and I will actually put it like full screen and go through the photos with you, because this case answers the questions that you got here. So what I'll do, I'll go to Zoom, I'll go to share, and we will share Lightroom. So, but please confirm that you see the photo of the case.
Yeah, perfect.
Perfect. So this is after the surgery, okay? We had a patient that she has a problem with this lower premolar. The problem was not only that she doesn't have enough hard tissues for the tooth to be restored, so that's why there's the orthodontic extrusion being prepared. She also had a problem with the apex of the tooth, and I don't have the X-ray here, but there was a broken instrument and there was periapical lesion in the area. I was not able to take it out endodontically. My colleague of mine was trying to do it; she wasn't able to do it. So we planned this surgery. And what we did was we accessed it from the side. So you can actually see here the guide is placed. And what you can do in the guide, you can actually define exactly where the window of the osteotomy will be. And you can actually measure in the software how deeply you will have to go with this instrument of piezo that I just described, the piezo for the sinus lift. This is not the tip that I use for the sinus lift. This is the tip that I use for the resection. And you actually design it so that you can measure the exact depth that you will go in. And then you place the guide, as you can see it's here. Actually, right here, what you can see is foramen mentale, the inferior mandibular nerve going in there. And you actually try to prep in 4 lines. Each line equals to the square of the guide right here. And so actually you go like this, and you know that that number 3 is 10 millimeters deep, which is the depth that you will need based on the plan. This is the result. You go 10 millimeters on each line. That means you define exactly where the osteotomy will be. And this is exactly the 3 millimeters of the root that we wanted. And then you remove it, and you can actually see, and then I separated the bone from the root. And I took the root out, of course, with the instrument and the infection. And I placed actually the bone. This is also checking if the filling of the root is correct, which was with the calcium silicate cement. And this is placing the bone back. And then this is the suture. So the answer to your question, how do you define exactly the osteotomy of the tip of the bone when doing the periapical surgery? And it's done by doing this type of guide, knowing the right depth of the piezo instrument. And you can see we actually designed exactly the block of the bone that will be removed with the tip of the root. So this is the answer.
Thanks a lot. Dear Dr. Jan Hulvert, on behalf of the IADS SCORE webinars team, we would like to extend our sincere thanks for your excellent presentation on guided surgery from plan to precision. Your comprehensive approach to the digital planning workflow provided our global community with a clear roadmap for achieving clinical accuracy. We truly appreciate the expertise and the clarity you brought to today's session. We look forward to the possibility of collaborating with you again in the future. With best regards, IADS SCORE webinars team. Thanks a lot, Doctor.
Thank you. Thank you for the invitation. Looking forward to next meeting again. And if there is any question, message me on Instagram. And if you could send me the link of the video that will be on YouTube, I will share it also, so you get as much viewers as possible. Thank you again.
Sure. Thanks a lot.